Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. We are on our third week or unit number 3, explaining on supply side of health or supply in healthcare. We have already started in the previous lecture on physician is healthcare provider, or physicians as health provider. So this is our lecture number second sequence of this particular lecture. We discuss about suppliers determine demand and also or the primary demand, as well as we discuss about supplier induced demand, SID. Trends in supply of physicians. Also we discussed supply induced demand from increase in physician density and conditions facilitating demand inducements. So the last couple of points will also re-emphasize in our lecture as well. We again focus on the supply induced demand through the physicians. So this is as follows. We'll talk about the physician's behavior through a model, and we'll also empirically examine the behavior, how it is optimal for the supply side. And there are some forms of discrimination made by physicians. One of the discrimination is through the racial one, or maybe through efficiency and non-efficiency based discrimination, etc. Will emphasize. Last but not the least aspect covered in this lecture is on labor market, as well as their wages, how responsible for determining supply in healthcare through the physicians. Once again, counting the assumptions, you can follow our previous lecture. For your knowledge, P we are taking as price, and A is largely the physician, which are considered to be identical, hence they are considered as identical physicians. N is the inhabitants or the persons or the patients. Then delta stands for A upon N. Basically we are counting this as physician density or physician population ratio. So this is the one we are going to use the most in our model. So our model is on physician behavior. So we start with no demand inducement, and if there is any inducement. If there is no inducement, as simple as that, that's basically called primary demand for physicians. It's precisely the cases or number of cases times the population divided by the identical physicians. So that's N by A, or A by N is precisely called the delta. So M upon delta is called the primary demand for physicians. Whereas when you use inducement, we already discussed how inducements are made in healthcare, and that's as we have seen in number of cases in Indian context in particular. Since supply side is quite less as compared to the demand side, hence supply inducement is expected to be very high, and so that supply the hospitals or the healthcare units used to provoke the patients in various ways to increase their demand. Hence, a component we are just adding, which is from the primary demand pattern, M upon delta plus S. S stands for the inducement, unit of inducements. So, M we have already discussed, that is called demand for physician services. So, we will be discussing all these in our model. And out of the total time, the time as a factor we are considering as well in the model, and we are also referring to the original author. There are some minor cosmetic changes to the author. We will also cite author's work at the end. And in this case, T, proportion of time that is utilized for healthcare and to induce the demand, we are saying that the optimum time proportion is 1, and out of that, at minimum of H time or H units of time is required for healthcare. Okay, and that is precisely a function of the induced content or the units and the delta. So, delta we have already mentioned that their density, okay, of for the physicians. We have already mentioned this physician density or physician population ratio. So, time constant we have emphasized. Now, we discuss about the disposable income and how it is actually inspiring the physician to be or the health units to influence the demand. So, disposable income of the physicians is largely a function of their revenue, which is basically P times T. P is we have already discussed here, the price, and T is the time, and the practice expenses, taxes, etc. Largely, I discussed in the last lecture that Y is actually other P and T, practice expenses and taxes are already part of the revenue PT. Hence, the simple function we are mentioning this is Y is equal to Y of PT. So, and this is considered to be a concave function with its feature as first order derivative to be positive and the second order derivative is negative. So, hence disposable income is an increasing and concave function of physicians consumption. Here the utility function is defined, and utility function is defined in terms of its disposable income, time and the induced demand. Physician's utility function is strictly concave. It depends positively on consumption and negatively on working hours or time and demand inducements. Okay. Hence, there are three possibility conditions. One is its first order derivative will be positive and second order negative, that is precisely called the concave function, and with respect to that is with respect to income, first order derivative with respect to income, and what happens to in terms of T, with respect to T, this is in terms of first one is in terms of Y, second one is on T, third one is in terms of the induced demand units. Okay. So, and there are possibilities with respect to T, of course, the utility when T increases, the utility actually declines, and in terms of induced demand also declines. There are also cross possibilities, complementary goods case when Y and T are complementing each other, consumption and leisure are actually complemented. Similarly, income and induced demand, that is also complementing each other. Then we have also tried to find their cross second order derivatives. Y observe that the second order derivative for Y and T, in that case it is considered to be non-positive, or and others like with Y and S is also non-positive, whereas in case of S and T, that is workload time has no effect, it is considered to be 0. The second order derivative here is considered to be 0, that means that workload time has no effect on physicians' attitude towards professional ethics. So, time has hardly any effects in terms of professional ethics. Hence, the change is considered to be 0. So, we are just highlighting this just to clarify that there is negative changes. Negative because it is incompatible with professional ethics. Okay, you can refer this the book which we have cited, and that will be useful further. A physician maximizes his or her utility with respect to y, t and s by choosing optimal amount. In that case may be y star, t star and a star. Given the constant will be, as I already mentioned, will be your that is your induced supply function. H should be equalized with the m upon delta plus s, that is the total induced supply, and H should be strictly positive, and T should be having a minimum level of H and 1. So, the optima we can discuss one by one. This is based on the market condition and physician preferences. So, all possibilities, that means S might be 0, S is basically induced supply, units might be 0, or T might be the maximum utilization, or other boundary possibilities. S equal to 0, T equal to T is less than 1, S is greater than 0, T is less than 1, and S is greater than 0 and T equal to 1, etc. All 4 possibilities are discussed. So, here when first boundary conditions occurs, both are 1, that means when physician density is low, okay. So, physician density is low, that market demand cannot be made with all physicians working maximum amount of time, okay. And second one case, inducement is actually 0, S equal to 0. When ethics or preferences for leisure are very strong, and even physicians are working below capacity, and but they are just meeting primary demand only. On the first case, T equal to 0, that means they are actually utilizing the maximum time, hence hardly there is any scope for the inducement. Then on the third one, that is called interior optimum, because both are the interior one. I mean S is non-equal and also T is non-equal to 1. In that case, when physician's density is so high that even with optimum amount of demand inducement, they are working below full capacity. Last one is called optimum with T equal to 1 and S, there is certain inducement, when physicians are inducing demand until full capacity is reached. These 3 requires, on the first one actually it is a simple Lagrangian optimization method is required, but other there are some inequalities conditions in the constant function, hence nonlinear programming is required, and Cohn-Tucker condition is usually suggested. So, these 3 cases requires Cohn-Tucker conditions. For the cases involving inequality, the Cohn-Tucker conditions will be formed as follows. First step, will put the total demand for physician's equations in utility functions, that is U equal to y, t and s, and of course this is a function of induced demand s only. The constant will be formed out of time constant, and it will be an inequality. So, the utility function is y, t and s. Y is y pt. So, y pt is explained over here. This is what is your t, and y is pt, and then this person is your t, then this is s, okay, and subject to t constraint is given, and inequality constants are like that delta induced supply function should be maximum, at maximum utilizing 1 or less of the time, okay, and at S is considered to be greater than or equal to 0, then only we are actually thinking of the Kontaker conditions. Now, if we make that inequality conditions equalized with the boundary, that means if we add certain dummy variable x, okay, then that might be equalized with 1, that m upon delta plus s plus x, we are just adding a dummy variable, so that will be equalized with 1, where x is considered to be non-negative restrictions. All right. So, to now consider a problem with non-negativity restrictions on the choice variables only, with no other constraints. So, we are, as an example, we are just maximizing profit or pi as a function of x subject to x is positive, okay, or greater than or equal to non-negative. So, we are just taking a non-negative restrictions on the choice variables. As a simple example, do you get optimized value in each case with first order derivative that is equal to 0? If not, then why? You can just see, if you will just take the first order derivative, since our constant function is actually 0 and greater than 0 or non-negative. So, in these functions you will find that the optimization occurs in first order derivative might occur at 0 place as well when x equal to 0. So, this really diluting the matter, that even if x or the units of supply is 0, still Hell conditioning or the maximization point occurs at 0 output, which seems to be unreal and not right, and hence the optimization this way, simple optimization techniques, is not actually clarifying the case. Hence, to explain all sort of things, we will discuss these 3 cases, case 1 and case 2 and case 3. So, case 1, basically the first order derivative is 0, and where the output is actually the x is positive, and whereas in case 2 and case 3, for the case 2, the first order derivative is 0, but in case 3 the first order derivative is actually optimizing, is tangential but not 0, it is actually less than 0. So, when it is first order derivative is 0, it gives a value x equal to 0, which is really not the case, not the right indicator of optimizing. So, another solution to this is actually 3 cases in our typical way of optimizing or optimizing condition is through the first order and second order derivative, and we usually equalizing is to 0. But if you take the product in 3 cases, but product wise, that is x times its first value of the first order derivative, this is in all cases this is optimizing and equal to 0. So, this can be considered as a solution for further use. Okay. So, we will be utilizing when non-negative restrictions are imposed in equality constant problem, the regular first order conditions becomes less than 0, and or x is greater than 0, or the product is actually product of these is equal to 0. The Lagrangian function will be formed by taking lambda as Lagrangian multiplier. Subsequently, the first order conditions in that case will be these. Okay. So, you have taken y, t and s with a Lagrangian constant function, and this is actually precisely m plus s m plus s plus x equal to 1. So, we have taken 1 minus this. So, this portion is actually equal to 0. So, lambda times 0 is 0. So, actually utility function is nothing but yp and yt and s. Through the Lagrangian optimizing formula, we used to take the conditions. In that case, with respect to s, we know that here, with respect to s, with respect to x, and with respect to lambda, three indicators are very important to discuss. So, when we take with respect to s, it is actually non-positive, and whereas the product, that is s time d g by ds is equal to 0, and then the product one is actually x times the first order derivative is equal to 0, and this is what we are going to use it, which we have started explaining here. This second aspect, that is the product, is going to be very useful. We note that dz by dx is nothing, that is basically minus lambda. We use this information to simplify, lambda. Once we define the value, that is basically useful for simplifying the condition. Now, simplifying this equation, we will get dj upon ds is non positive, and the product is 0. So, by solving this, we will find that I will solve this equations, and these conditions are usually called Kohn-Tucker conditions. Once we find dj upon d lambda, and finally we arrive into the solutions, and these are the necessary conditions for the optimization problem. We will also clarify the exact interpretation of it. You will get n number of equation for n variable, and to solve them to get optimal solution for the extremum. Then the fourth step is to confirm whether the extremum is maximum or minimum, and we check the second order condition as below. So, we in that case, when there are first order condition and second order condition, they all together decide the solution. We used to take the border Hessian determinant. So, we use border Hessian that is H form, that is mixed matrix of first and second order derivative of the objective and constant equations. So, to maximize the z function of with and subject to the constant functions. Okay. And so this is what is interpreted at this moment. For your reference, you can follow the book and the mathematical economics books to get the idea of border Hessian determinants. Hence, in 4 cases which I have started explaining, they are actually starting with the boundary optimum, then Kohn-Tucker conditions. We will also re-emphasize this. So, the solutions would be, with the simple example, would be given that t equal to 1, we have taken that t equal to 1 the first case. Hence, the y is equal to only yp, no t is no longer there, hence the utility function will be y in terms of p. Okay. So, effect of increase in delta on number of services provided per patient, that is Q. So, delta is very low, such that such that the m upon delta should be greater than equal to 1, that is the primary demand exceeds the physician's working capacity, with the constant of t is less than equal to 1 is binding. Since t equal to 1 in our case, and physician supply is measured in units of physician's working time, physician supply would be of course equal to, we have already explained, A is our supply, physician supply. Now, in this case it will be A times 1 unit per patient physician supply is equal to A upon n, which is precisely the delta. Hence, Q is equal to A upon n, which already mentioned as Q in our example. Okay. Then so if, and that is precisely the delta. you take dq by d delta, it is equal to 1. This means that the billings per patients are proportional to physician density. So, once the physician density increases, billing proportional, the patients are considered to be proportional to it. This is basically the first one. Second, third and fourth conditions are out of the Kontaker formula, Kontaker conditions. We will find a number of things. We start with s equal to 0, hence in a function, utility function, you will see this. This is 0 is given, rest are as per our discussion we made it in the previous one. So, basically we want to say here that the effect of increase in delta, that is the doctors induce demand for health, effect of this induced demand for health on number of services provided per patient. In this case, physicians do not induce demand because of preference for leisure and ethical orientations, since s equal to 0. Hence, q is equal to m, that is whatever the q was there, that is not precisely the primary demand. Hence, dq by d delta is equal to 0. So, in this case, billings per patient do not depend upon physician density in this range of delta. Whereas, in another interior optimum case, we will see that all have certain value. So, it is little complicated. So, the optimum conditions will be p times first order derivative and its y prime u prime, and with respect to t and with respect to s, that should be equal to 0. So, s is the function of exogenous variable, in this case that is variables, okay, and s is a function of here delta, p and m. So, in this case, the demand is induced to the point where the marginal benefit of additional consumption equals the marginal utility loss of the additional working hours and the bad conscience resulting from demand inducement. As a solution to it, precisely you can see the same equation where just there is a minor change, s plus delta times ds upon dq, which we did in the previous two cases. So, there are two effects in this case, one is direct and indirect effect. Indirect effect is that it depends upon the impact of delta on demand inducement at the level ds upon d delta. The last one, again it has certain boundary conditions, that T is used as with the full capacity. So, in this case S is equal to 1 minus m upon delta. So, as delta increases or the induced demand increases, physician density actually increases, alright. So, and the effect of increase in this on delta on the patient is that m upon I mean this is similar to that of first case. Here we have binding time constant, but sigma the delta is high, hence m upon delta is less than 1. This implies high motive for induced demand up to the full capacity as due to high competition working below competition. Physician supply would be of course A times 1 units per patient, physician supply will be A upon n, and by all possibilities dq by d delta is equal to 1. That means billings per patients are proportional to that of physician density as long as all physicians work at full capacity. Okay. So, you can just see all three 4 cases are actually discussed in 3 regions. You can see till here we are discussing physician density and physician billing per patient, that is Q. Okay. So, till it is M level is reached, that is primary demand, you will see that physician billing per patient is proportionately higher. First region of the straight line shows case 1 and 4, which the stage 1, stage 2, stage 4, out of that 1 and 4 basically it increases. And in region 2, horizontal line shows case 2 of without demand inducement exists, whereas case 3 in the region 3 with 2 effects, direct and indirect effect. Okay. So that depends upon the indicators which I already discussed. So, theory of supply induced demand, that is SID, is so far as SID is concerned, that is the SID is concerned with physicians reaction to changes in physician density and the level of regulated fees, that is P. It has effect of physician density, that means if physician density varies with cases of optimality, and effect of fee level is ambiguous because of the substitution and income effect leads to increase and decrease in service volume respectively. There are some empirical identification by different other authors. Fuchs 78 in his paper discuss about cross sectional study based on USA between 1963 to 1970. They observed that an increase in 10% in surgeons density leads to a 3% increase in the number of surgery, keeping other variable constant, and this also support the SID hypothesis we already discussed. Similarly, another case identified by some authors, it is on rising hysterectomy cases in India. Some papers, C. Devnath, working paper you can refer. That is on growth of these cases in private hospitals. It is higher than that of the growth of cases in public hospitals. This indicates supply induced units for health access or health demand. And similar trends can also be observed in the C-section, cesarean sections deliveries in Indian context. Especially highly cases are rising over the recent years and especially observed in private hospitals. SID is one explanation for increasing utilization of medical services per capita with increasing physician density, keeping prices constant. This indicates permanent excess demand, decreasing indirect cost, improved quality of treatment, defensive medicines, reverse causality, etc. So, if permanent demand is higher, then that D is much higher than that of the induced cases. That might be excess than that of the induced cases. Physicians have to turn away some patients. The left patients go to new physicians, and this case correspond to S equal to 0 and T equal to 1, that is the optimum one. So, this is basically effect of a supply extension at regulated price and excess demand. So, when excess demand is there, so supply curve has the tendency to actually reach to that level, since already demand is there, all right. So, and that is why it is called permanent excess demand, and it is largely affected by number of reasons. Maybe due to decreasing indirect costs, improved quality of treatment. New physicians in proximity means reduction in non-financial costs, such as getting faster appointment, less travel time, and time devoted to each case increases. Hence, demand shifts rightwards, and more new demand at a given money or price is there. Defensive medicines are prescribed, such as medicine which are actually for doctor's perspective, that will work as a kind of defensive measures. This is departing from best medical practices to minimize the likelihood of patients conflict, particularly in the context of malpractice litigations. Reverse causality, if any is there, then that might induce the demand. New physicians are coming to places with more demand, and rather than demand is coming with more physicians. Consequently, high per capita utilization of medical services leads to high physicians density on average. Similarly, there are certain supply side perspective observed through racial discrimination by physicians. It is sometimes due to the test based discrimination, due to statistical discrimination, due to efficient and inefficient discrimination. So far as test based is concerned, I mean there are lots of stereotypes involved in our medical consultations. I mean doctors or the physician may or may not interact the patient because of their color or race. They may not treat subject to patients based on belief that they won't follow up medication or aren't good candidate for treatment. So that's based on some statistical discrimination they make. Then there are some discrimination based on welfare point of view, that's basically efficient and inefficient. Which one is going to be efficiently stepping up the physicians, and accordingly more facilities are provided. So, discrimination and health disparities are actually correlated. Other indicators such as wage rate and labor market for the physicians are very essential. This helps in deciding the initial level or the decision for the physician to act as a physician, or the decision to specialize, and decision about how much of work is there once physician has a complete training. But you know that training requires more time, and the demand in the market may not be catched up to the supply because of the training period. Training of the physicians will show one chart that really time consuming, and there are also entry barriers, eligibility criteria, etc. As part of entry barrier, then license to practice, etc. So these also result in some monopoly rents that has negative implications on the supply or the supply induced demand, and another one is that might be positively impacting because of positive or the better quality of healthcare. So this is the chart of US, the time requirement in years of various residency and fellowship program to act as a physician, starting with a medical school, then different services. The time it requires, age of typical medical student. So in different years they are capable of treating. We are referring to J. Bhattacharya et al. 2013 Health Economics, chapter number 5. Similarly, physician wages, even if the training period of physician is similar, their wages differ across countries, and supplies induced demand is different due to salary differential. Newly trained physicians may migrate to countries with better wages. Healthcare in India becomes less accessible due to number of cases of brain drain. Okay, so this is what the country is experiencing doctor brain drain. You can see highest is noted in India, Indian cases, because of the wage rate is very different. India, UK, US and Canada and UAE by PPP term, the salaries in US dollar in 2017 is given, and India's figures are much lesser. Hence, doctors or the physician prefer to migrate to the countries where they will earn better. We are referring to Statista database. It is also available in our institute. You can also refer the online documents for it for the record. I think these are all for the physician acting as a supply induced healthcare demand. Okay, so that's all. In the next lecture, we will continue physician as a provider of health, and we will also discuss the role of hospital as health provider as well. So references we have cited, and I think will be useful. Thank you.